welcome everybody, and there has been a lot of interest in the last couple of years on how to improve glycemic monitoring in the hospital, especially during the pandemic. That has really pushed the field forward, and it is my pleasure to present to you what we have done and what we're doing in the hospital setting. Oops. These are potential conflict of interest, and we have conducted clinical investigator-initiated studies. All the funding goes to Emory University, not to my family. Currently, we receive funding from Novo Nordisk, AstraZeneca, and Descom. So the agenda for today. I will discuss with you the traditional glucose monitoring approach, so the self-glucose monitoring or finger sticks, how the CGM has come into a active player in glucose monitoring, especially describing the limitation of the traditional point of care testing. What is the really efficacy? What data we have? How can we use CGM during the COVID pandemic? And we will discuss at the end new challenges or addressing how we can, adopt CGM in the hospital setting. So let me start with this slide. And this is just data from last year from the Center for Disease Control. To the left is the number of people with diabetes in this country, is now over 34 million. And to the right is hospital discharge. So there are close to 8 million hospital discharges every year with the diagnosis of diabetes. And there's about 16 million emergency room visits because of diabetes. Overall, it is estimated the cost of diabetes care is somewhere around $300 billion, with 30%, so over $1 billion, $100 billion is spent in the inpatient care of diabetes. This slide is one of my favorite, that it really highlights the frequency of hyperglycemia in the hospital setting. This is data from the group of Curtis Cook from the Mayo Clinic in Arizona. And in the top is ICU, and in the bottom, non-ICU. And these are people in 12 million blood glucose readings. And what you look is that it doesn't matter where you are, in the ICU, non-ICU, about 32% of blood glucose readings are above 180. If you are one of those that, well, 180 is not too bad, but if you said, well, what about 200? And about 23%, independent if you're located in the ICU, non-ICU, have hyperglycemia greater than 200, and about 10% greater than 250. And that is important because hyperglycemia, both in patients with and without diabetes, has been associated with an increased rate of complications. And this is data that we published from Emory, a composite of complications that included pneumonia, acute kidney injury, acute respiratory failure, acute MI, bacteremia, and death. So we did a composite. And what you're looking is that the higher the blood glucose, the higher the rate of complications. And if you have, 200 or more, the rate of complication is close to 40%. But you can have normal blood glucose and you still have complications. And this is because hyperglycemia favors the appearance of complications, but it's not the only reason why people develop complications in the hospital. So hyperglycemia is a marker of poor outcome, both in patients with and without diabetes. And the data that I presented to you, this is with finger sticks. And the self-glucose monitoring has been great help during the past almost 50 years. It's used in the hospital and it tells you in real time what the blood glucose concentration is. It's rapid, you get the response in seconds. It can tell you if the patient is in hypo and hyperglycemia, but it requires multiple finger sticks, especially in the ICU, where doing insulin infusion, we measure blood glucose every 1 or 2 hours. And in the non-ICU, most of the guidelines recommend to test the blood glucose before meals and at bedtime. So, great benefit. It's easy to do. It's widespread adoption in every single hospital around the country, around the world. You can adjust your therapy according to blood glucose levels, and this is the way we have done during the past few years. So this is the good part. But there are several limitations. For example, you only get a point or 3 or 4 points throughout the day, so you don't know what happened in between readings. It doesn't provide the direction or the velocity of changes of glucose levels. And more importantly, several studies have shown that you miss a lot of hypos and hypers events. So especially at night, that's right, from 10 p.m. to 6 o'clock in the morning, we don't do glucose testing. And in the recent studies that we published from our group, we went to the bedside every time a blood glucose was less than 70. And we asked the patient to determine symptoms, to determine the presence of symptomatic and asymptomatic hypoglycemia. And about 45% of the events were asymptomatic. So there was no tremors, no sweating. Patient was just fine. And the predictors of asymptomatic hypoglycemia were age. And you will see that compared to patients less than 50 to your right in the table, having an age between 50 to 58, 59 to 64, and more than 65 will increase the rate of asymptomatic hypoglycemia from 2 to 4-fold. Of great interest was also the finding that male sex was also is a risk factor for asymptomatic hypoglycemia in the hospital, where the asymptomatic hypoglycemia rate was twice as much as females. And in addition, the glomerular filtration rate. So there are many patients in the hospital who suffer asymptomatic hypoglycemia. These were patients with type 2. And the other thing that is important is the prevalence or the frequency of inpatient hypoglycemia in type 1 has been reported somewhere between 50 up to 45% of patients. So CGM may help in determining and picking up these events that you don't do finger sticks, but every 3 or 4 times a day. So when we talk about CGM, there are several devices, that's right. There are devices, we call it invasive, they're intravascular or venous or arterial. Minimally invasive, that's what we use mostly in the ambulatory setting. There are subcutaneous, and there's also transdermal. The characteristic of CGM is the frequent sampling, where blood glucose measures are done every 1 to 15 minutes. And this is what we call continuous glucose monitoring. And they're not approved for hospital use. However, the FDA is allowed, especially during the pandemic, to use CGM to assess glycemic control in order to minimize PPE and staff exposure to patients with COVID. More importantly, several consensus and medical societies have reported that CGM technology offers benefits in prevention of severe hyperglycemia and hypoglycemic events. So I believe that during the next few years, we're going to be conducting the studies to determine if CGM can be approved by FDA for hospital use. But the data from the ambulatory setting is very encouraging. For example, in this meta-analysis in ambulatory patients, CGM was able to recognize and to reduce the rate of hypoglycemia in patients with multi-dose insulin and pump therapy. Can we reproduce this data in the hospital? So let's review where we are. In the intensive care unit, there are a large number of studies, over 30 studies, that have tested CGM in the ICU. This is one example. And you see that in the regimen trial, these are patients that were monitored for 96 hours for intensive glucose control in the ICU. And you see that there is a very good correlation between point of care testing or a blood glucose by the laboratory, where we call the error grid zones A and B. That's where you would like to be, that's right. And about 98.6%. But the CGM did not reduce or improve glycemic variability or reduce the number of hypoglycemic events. And that finding has been reproduced in multiple studies. And in part, it's because you do in the ICU, you measure blood glucose every hour. So you can adjust insulin infusion the same by frequent measurements by point of care testing or by CGM. And in the systematic review of 37 studies, both randomized and observational studies concluded that CGM has very good correlation with the laboratory, but does not improve glycemic control in the ICU patients in a significant manner. So for many years, we have had the CGM that have not made a great impact until recently, when COVID made its appearance. And during the past year, there have been several studies from our group and others to use CGM with remote continuous glucose monitoring to reduce the use of PPE and decrease the exposure of house staff. And of course, there is such an importance, and this is data we just published a couple months ago, in over 1,000 patients to determine that in COVID patients, those who have hyperglycemia greater than 250 in red have significant worse outcome and mortality compared to those who have better glucose control. Even those patients with or without diabetes, with a glucose greater than 250 in the ICU and non-ICU, is associated with 2 to 5-fold increase in mortality. So there is a need for monitoring. So Dr. Agarwal from Montefiore just published this data in collaboration with Emory. And what they're doing is to place a CGM, and to see in the right part of this slide, and they attach them to the wall of the ICU, and people can be tracking information. And to the right is the correlation between point of care testing with the CGM. And you see in here, there is a very nice correlation with somewhere around 98.2% of all the blood glucose reading within the error grid zones A and B, so a very good correlation. And the MARD in this study was 12.5, so a very acceptable in the ICU. We have also established the use of CGM for remote glucose monitoring in all the COVID units and also in the ICU. And using the DESCOM monitoring, we get the CGM and we transmit the data. And more importantly, now we pair with the glucometer a computerized insulin infusion protocol to adjust insulin therapy. And instead of measuring blood glucose every hour, we just measure the blood glucose 3 or 4 times a day, every 6 hours, just to make sure everything is doing well. And we're able to connect to electronic health records for validation. And here you have the CGM device that can be placed up to 20 feet from the meter or from the patient's bed. And next to it has the glucometer or the insulin infusion protocol. And then you have the readings, and you can adjust the blood glucose, the insulin infusion according to the blood glucose. And more importantly, not only that you have this CGM and the readers at the wall of the ICU bed, but more importantly, we can transmit this information all the way to the nurses' stations. And because we have alarms now, it's easy to detect when the blood glucose is going down, with the arrows going down, call the nurse, and the nurse go to prick the fingers and prevent hypoglycemia. So we just published this data just this month, in which we can see here in patients with COVID, a very nice correlation between the point of care testing and 4 times a day blood glucose instead of every hour. And you see, and that will allow to improve glycemic control reduce the rate of hypoglycemia in these patients. So can we use the CGM in the ICU? Yes, but there are some limitations in the ICU. First, there is substance interference. We'll discuss this in a minute. There is a measurement lag about a few minutes, about 7 to 15 minutes. We really don't know what's the accuracy in periods of arterial hypotension. What happened with hypoxia, hypothermia? We need more studies in the ICU. Also, intravascular catheters at risk of thrombus and infections, and of course, there is the cost. So in the ICU, I think that CGM is still a lot to work to do to establish a beneficial effects compared to frequent point of glucose testing. What really has made a revolution in diabetes care in the hospital is in the non-ICU setting. This is an abbreviated list of papers that we and others have published with different CGM that you see here in the non-ICU setting. And this is for accuracy and performance measurements compared to different point of care testing. Let me review some of these data. With Ana Maria Gomez, one of my colleagues, we published this data using the iPro. And what you see here is the correlation to the left between CGM and point of care testing at different days of hospital admission to the hospital insulin treatment. And to the right, a very good correlation, same like was being published before. So that in the first studies now just published 3 or 4 years ago, we just saw this very nice correlation. There are other authors has published similar data. And here you have to the top is hypoglycemia, less than 54, and hyperglycemia greater than 250 at the bottom. And you see that compared to point of care testing glucose, the CGM is able to recognize significant larger number of hypoglycemic events throughout the day or throughout the night. And also recognize more hyperglycemic events. And more importantly, remember what I showed you, many of these episodes are asymptomatic. And the only way to recognize this is by measuring blood glucose. In a recent paper published August last year in Diabetes Care, my colleague Rodolfo Galindo published this data using the Freestyle Libre Pro Flash CGM compared to the point of care testing. Look here to the figure to the left. And you see that point of care testing reached somewhere around 12 milligrams higher blood glucose than CGM, but throughout the blood glucose in different days of hospital stay, you see this very nice correlation. We order point of care testing before meals and at bedtime. That means between 10 p.m. to 6 a.m., very few blood glucose testing was done, unless somebody developed symptoms. And that allowed to recognize that point of care testing is not as good in detecting hypo and hyper event, especially hypoglycemia. Here you have with point of care testing, you have significant less hypoglycemia recognition. And with CGM, we are able to recognize significant, much better numbers of less than 54, especially nocturnal hypoglycemia. Look at the number of hypoglycemic events during the night, 10 p.m. to 6 a.m. Even here to the right is prolonged hypoglycemia, what we define as a low blood sugars continuously for up to 2 hours during the day or during the night. That's the beauty of the CGM in the hospital setting. In the studies that Diabetes Care from Galindo, we saw that the Clark error A and B is 98.5%. And here you have the MARD. In this study was 14.8. Very good for glucose within the normal range or above range. And many, like, they're not designed for a glucose less than 70. The MARD was significant higher. And in the paper that is we presented at the ADA last year, is under review in Diabetes Care, and you have the use of Dexcom G6 CGM. And overall, the the Clark error A and B is somewhere around 98.5, 98.7%. Then we ask, what happened during the first 12 hours versus the first 24 hours? To the left is the relationship between the point of care testing and the CGM readings, where you see that it's also 98.5% during the first 12 hours, and the same thing during the first 24 hours during the hospital stay. So excellent correlation with point of care testing. We also learned in these 205 patients that were all insulin treated with type 2 diabetes in general medicine and surgical wards, that it works very well for glucose greater than 70, with an MARD about 12. But for hypoglycemia, similar to what we saw on the Libre Pro, with the hypoglycemia, the Dexcom CGM have a higher MARD. So what we have done now in the hospital is the blood glucose is less than 80, 90. It's better to trust or do a point of care testing to confirm hypoglycemia. Also, in the middle bars, you see the level of hemoglobin. And severe anemia with 7 grams of hemoglobin or less also has worse performance. So much more studies are needed to assess the performance of CGM in patients with severe anemia and hypoglycemia. Well, what's good is that there are many other reasons in which there was a good correlation. There was no failure of the CGM on accuracy. For example, according to GFR. So even in patients with end-stage renal disease and dialysis, it works. However, if they are very anemic, that may fail. But here you have the GFR with more than 90, 60 to 90, or less than 30. The MARD was very acceptable range. We have also looked at race. Blacks versus Caucasians, no difference. The BMI doesn't change. And also, we just reported at the ADA, the placement in the abdomen versus arm performs very well. So very nice correlation. It helps. So one of the limitations is that so far we have the CGM, you have the sensor, you have the receiver. How can you transmit this to the nurse stations or to the wall, as I showed you before? And we have been working with Dr. Spanaskis and his group at the University of Maryland for the last few years, reporting on what we call the glucose telemetry system. And you have this CGM in the arm, in the abdomen, is transmitted. And here you have, although you can't see, same as cardiology have the Holter, we have the glucose telemetry system with 24/7 blood glucose levels. And we report what is called the hospital glucose profile. So we can get the average blood glucose, the changes of blood glucose throughout the day. Here you have day 1, day 2, and day 3. And then you can see the number of patients who have glucose in target range. So between, here it's good, about 80.9, high blood glucose. You can also have glycemic variability on a daily basis and the time. So using this glucose telemetry system, now we recently reported with the group at the University of Maryland that you can reduce the rate of hypoglycemic events. So in this study of patients that were insulin treated, we had an order that if the blood glucose was less than 85, it has an alarm, and the nurses were indicated or were asked to go to the bedside, do the finger sticks, and treat accordingly to prevent severe hypoglycemia. And what we reported is that the number of episodes of hypoglycemia, because we can treat the patient, don't wait until the 60, 70, we just give some orange juice, crackers, or whatever is needed for glucose less than 85, and you can prevent hypoglycemia. And here to the right is the time below range, where we have a significant reduction in the time of hypoglycemia. So if we believe that hypoglycemia is associated with poor outcomes, same as hyperglycemia, CGM allows you to reduce the risk of complications. So what is in the pipeline? This is what we have so far. First, Now we just completed a study in which we prospectively doing an intervention studies where patients are managed with the standard of care point of care testing. So you adjust insulin therapy according to the point of care testing 4 times a day versus CGM. The studies right now, we took patients to type 1 and type 2 with blood glucose between 140 and 400. We are analyzing the data. I hope that we're going to prove that we can reduce hypo events. There are also implantable sensors. That's right. Right now, they're approved to 90 days in the US and now 180 days in Europe. This is something that is going to be happening in the future. We're not done any study with Eversense. There is the issue that what happens if the patient needs an MRI, then you can run into problems. So the other is closed loop. That's right. There are several studies reported in the UK that the use of closed loop, so having a CGM connected to an insulin infusion or an insulin pump, you can improve glycemic control, reduce average blood glucose, and decrease glycemic variability in patients. We are now working with one of these in Omnipod in a very preliminary studies, and we planning to test if the closed loop system can be an option for management patients in the hospital setting. But there are different challenges, that's right. I mean, it's easy to do studies, but in real world, let me just discuss some of the challenges that I think has to be considered for the hospital care. First, many of the primary care and hospitalists are not familiar with the technology. So we need to do a lot of educations. Our hospitalists don't use CGM on a routine basis, so education is needed. So I hope that presentation like this help to open our mind to be able to use this CGM technology in the future. Second, there are some CGM that need calibration. There is this measurement lag because what it measures is subcutaneous tissue, interstitial fluid. And there is somewhere between 7 to 15 minutes delay. Is that important? Well, if you're using as an outpatient in the ambulatory setting or you do it in the non-ICU, maybe no. Interfering with high doses of acetaminophen or ascorbic acid and others has to be learned. The other thing that some of my colleagues say, well, maybe there is an information overload. If you get this blood glucose measured every 5-15 minutes throughout the day, can you react and maybe do insulin stocking? So we just need to learn more, and more importantly, teach our house staff, teach our primary care hospitalists on the appropriate use of CGM. So we're doing studies now in patients with hypotension, hypothermia, hypoxia. What's going on with in the ICU? I already told you that I don't think this is the best thing for the ICU, but for the non-ICU, it is an alternative to frequent blood glucose testing. Cost is an issue, but cost is coming down, and finger sticks are not cheap, especially because of the nursing time that is done. So the other thing is what we call discrepancy. And this is an interesting case, that's right. Let me present this to you. This is a 54-year-old male who is admitted with a diabetic foot ulcer. And what you have here in black numbers are the blood glucose levels by point of care testing, so finger sticks. And in the green color in the bottom are those measured by CGM. And overall, there's a good correlation, but there are some values like this. What would you do if it's 113 versus 77, or here, 88 by point of care testing, 54 by finger sticks? So in that case, we react for the lower blood glucose and we treat the patients. But I told you that the point of care testing is better than CGM for blood glucose less than 54 or less than 70. So we have to learn more how to adjust this or how often this is happening. The other thing is in the ICU. This is data we just published last month in Diabetes Care. And here you have to the left, look at what is called in the panel C, that Patient goes to the OR. This is bypass surgery. This is Dr. Pascal and his group. And what you have is, let's say, this patient here, when it went in, surgery start is in the green arrows, the bypass is on in the orange, and when surgery ends is in the red. And CGM is in blue and point of care testing is in red. So this patient, for example, during the CGM value stop, when the patient, the surgery start, and when the bypass is on, and after surgery, it came back, perfect. And all of them fails. And there are many patients who undergo bypass surgery, maybe because of changes in temperature or extracorporeal circulation, you're going to have failures of CGM. In some of them, it comes back after surgery, but in others do not recover. So what we're doing right now, for example, look at this. They started the surgery, it went blank, and it didn't recover after several hours after surgery. And in others, they reach much lower. So we think that in patients with bypass, what we're doing is we use the CGM, but you have to restart the CGM or put a new one, especially if it's not recovered after surgery. So that's the most appropriate way. I think that during surgery, maybe just do finger sticks may be indicated and may be safer for the patients. I'm sure some of you say, well, how do I implement continuous glucose monitoring in the hospital? And our group and others has published recent papers, and this is in Diabetes, Journal of Diabetes Science Technology last year, that we put characteristics of the two factory calibrated. And you know, the DESCOM start in 2 hours, the AVO 3 in 1 hour. Both of them look at glucose between 40, 50 up to 400 or 500. Big differences in the DESCOM is 10 days, 14 days for the Libre. It looked like the DESCOM G7 is going to go all the way to 14 days in the future. There is some interaction with acetaminophen or high doses of vitamin C of aspirin, so you have to be aware of that. Hydroxyurea for the DESCOM. So, and both, as I mentioned before, has some limitations that you can review this in the paper. But more importantly, in this publication, it tells you how do you download the data. That is beyond this presentation, but what you do is with the Clarity DESCOM website, or you do with the Live Review, and its paper tells you step by step how you get this data. How can you download it? Something that I am extremely proud of the work that some of my colleagues at Emory are doing is like Pascal is putting this together, this COVID in Diabetes website. It is just amazing. I would invite you to go to www.covidindiabetes.org, covidindiabetes.org. And it tells you in this, I mean, you can get very up-to-date PDF and good literature on the use of management of patients with COVID in the hospital. It gives you a protocol, how you treat steroid-induced or DKA in patients with COVID, both in the non-ICU and the ICU. And it has a whole section on diabetes technology and implementation. How do you use CGM or pump therapy in the hospital setting? Again, www.covidindiabetes.org. So in summary, what I have tried to tell you. The data from current studies, and we are conducting several more, and many more data, much data is coming in the next year or two, clearly shows that continuous glucose monitoring provides a better picture of glycemic control, glycemic status, compared to point-of-care testing. It detects hypoglycemia, significantly more events, especially nocturnal hypoglycemia. It gives you the direction and the magnitude of changes. So it's a much better tool. However, we still need more data to prove the accuracy of the sensor. How can we do this? We just need more studies. We also need studies that are being evaluated by the FDA to determine in a very scientific way if the use of CGM is accurate enough to replace point-of-care testing, or in high-risk population with hypoglycemia or complicated cases, maybe should be used. But if with that, we also need significant education and training programs, not only for physicians, but also for nurses and everybody, pharmacists and everybody involved in the management of patients with diabetes. We need to work on data transmission, that's right, from the bedside to the nursing stations. So a continuous glucose profile or telemedicine that we're doing, some of these companies are working on a dashboard where you can increase and recognize transmission, and more importantly, enter data on the electronic health records. We need pharmacoeconomic analysis. Is the use of CGM cheaper or more expensive than point-of-care testing? I think at the end would be much cheaper, especially in complicated patients, not only because finger sticks are expensive, but by reducing hypoglycemia and complications. And of course, we need more data like the one we just reported, combining the glucose monitoring with insulin administration, like there are many of these automatic insulin dosing systems that improve glycemic control. So I thank you very much for the opportunity to share with you where we are with the use of continuous glucose monitoring in the hospital setting. And I'm so pleased and glad that you are joining us today. And I hope that you will continue to join us in the future